Hello, I'm Dr. Richard Silver, Professor of Medicine in the Division of Rheumatology and Immunology at the Medical University of South Carolina. Thank you for joining me for this presentation entitled Identifying Autoimmune Interstitial Lung Diseases, a Rheumatologist's Perspective. This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals Incorporated. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines. The interstitial lung diseases are a diverse group of conditions that result in lung fibrosis. This table shows 5 main types of interstitial lung disease. On your left are the idiopathic ILDs, the prototype of which is idiopathic pulmonary fibrosis, or IPF. Then there's a group of patients who have hypersensitivity pneumonitis related to environmental exposures. There's sarcoidosis and a host of other rare interstitial lung diseases. For the purpose of this presentation, we'll focus on the interstitial lung disease associated with connective tissue disease. The autoimmune interstitial lung diseases include rheumatoid arthritis, systemic scleroderma, poly and dermatomyositis, and less frequently, systemic lupus, mixed connective tissue disease, and Sjogren's syndrome. And finally, there's a group of conditions known as interstitial pneumonia with autoimmune features. These patients may have interstitial lung disease and autoantibodies or other features of a connective tissue disease without fulfilling the specific classification of a given connective tissue disease. This slide is a cartoon illustrating the pathogenesis of fibrosis of the lung. When the lung is insulted, normal wound healing occurs, resulting in restoration of normal lung architecture and physiology. However, in patients with ILD, including those with connective tissue disease, the lung insult is more persistent and chronic, and abnormal wound healing arises, leading to fibrosis of the lung. The normal lung architecture is damaged, resulting in compromised gas exchange and ultimately respiratory failure. When considering interstitial lung disease among patients with connective tissue disease, it's important to obtain a history that would include the patient's exercise capacity, whether there's any dyspnea or shortness of breath, whether there's a cough. Such patients usually have a chronic, non-productive cough, and it's always important to search for any family history of autoimmune or interstitial lung disease. The physical examination is also very important, and one should listen carefully, auscultating the lungs and the lower bases in particular, listening for those fine inspiratory crackles or rowels. Spirometry and diffusion capacity and as parts of the pulmonary function test are also very important. And as you will see, lung imaging, particularly with high-resolution CT scan, is also very important. Once interstitial lung disease has been identified in a connective tissue disease patient, it's important to assess for progression of chronic fibrosis. This could result in the patient's loss of exercise capacity or a decrease in their ability to do their activities of daily living. There could be worsening cough. There could be a decline in forced vital capacity or diffusion capacity on pulmonary function testing. And there could be an increase in the extent of fibrosis on CT scan. Patients who report dyspnea should undergo complete pulmonary function tests. This table shows the different patterns that may be observed. There could be an obstructive component, a restrictive component, or a mixed component. The classic finding in patients with interstitial lung disease is a restrictive pattern, where the FVC is decreased, the FEV1 may be decreased, normal, or increased, and the FEV1-FVC ratio can be normal or increased. The diffusion is also decreased. Some of our patients, however, have underlying pulmonary disease aside from ILD, including asthma or COPD. These can have an obstructive pattern, and thus one might see a mixed pattern on pulmonary function testing. The CT scan is absolutely essential in evaluating patients for ILD. It gives much greater definition than a routine chest radiograph. Things for the radiologist to look at are features such as honeycombing, traction bronchiectasis, or reticulation, which are markers of fibrosis, and other features such as ground glass opacification, which would suggest active inflammation, airspace consolidation, air trapping, or nodular densities. The distribution is also important. Most patients with CTD-ILD will have a peripheral and a basilar prominent distribution to their fibrotic changes. With that in mind, I'm now going to turn to identifying interstitial lung disease in the connective tissue disease patient. The connective tissue diseases are a spectrum of systemic autoimmune disorders with significant heterogeneity characterized by immune-mediated organ dysfunction. The lung is a frequent target organ of the various connective tissue diseases, and all CTD patients are at risk for developing ILD. Rheumatoid arthritis, systemic sclerosis or scleroderma, and the idiopathic inflammatory myopathies, poly and dermatomyositis, are the diseases which place patients at particularly high risk for ILD. Early recognition based on symptoms and signs and confirmed with PFTs and HRCT scans is essential and may direct treatment of the CTD-ILD patient. I'm now going to present 3 cases from my own practice at an academic rheumatology center, which illustrate the ways in which ILD may present in a patient with an underlying connective tissue disease. The first case is that of rheumatoid arthritis-associated ILD. This is an 83-year-old male who presented with a chief complaint of shortness of breath. In the past, he was noted to have osteoarthritis with chondrocalcinosis, osteopenia, a history of bladder cancer, and a history of benign prostatic hyperplasia. He had a remote 10-year smoking history. He had no known environmental or occupational exposures. He presented initially, after having had osteoarthritis for many years, with a change in his symptoms, where he had an inflammatory polyarthritis, and at that time he was noted to have a SED rate of 55, a CRP of 3.64, and he was found to have a positive rheumatoid factor at a relatively high titer, as well as CCP autoantibodies. At that time, he was diagnosed with seropositive rheumatoid arthritis